Hello, everybody. It's a pleasure and an honor to be able to present to you folks today to go through this this presentation. This is really the first of two. The follow-on will sort of become obvious as we go through this, and we haven't got that scheduled, but at some point, hopefully we can. And that will be more focused on how to talk to your patients about the things that I'm going to present. But we need to go through first the foundation for talking to patients about really psychophysical disorders. In this case, we're going to focus on pain, but disorders, maybe we don't use that term, patient experiences that come across as physical that are driven by psychological factors, changes in the nervous system, and so on. So we'll focus on pain, and we'll talk a little bit today about the opioid crisis, just relate what I'm telling you about pain to the opioid crisis. And since we're talking a little bit about the opioid crisis, I just wanted to review this slide with you at the beginning. I think I'll come back to this once more, but I'm finding that a lot of folks aren't aware of how we're doing or not doing with the opioid crisis. So let's just paint it. The opioid crisis was deaths from, initially deaths from prescription opioids, accidental deaths from prescription opioids. It's become, of course, more along the lines of accidental overdoses on street opioids, especially fentanyl, since that came out. In 2010, the CDC and the government recorded 21,000 deaths, accidental deaths from prescription opioid, and that was an alarming number. It was about a fourfold increase from 10 years before. In 2019, that number had more than doubled. So that's just a few years ago. And this is after we really got after the opioid crisis in 2010, 11, 12 by trying to crack down on pill mills and a variety of other things, and brought out MAT therapy and naloxone and all this other stuff. But still, we've seen a big increase in accidental overdose deaths on all opioids, 49,000. That 2019 number is expected to double by 2025, and that's the number that I don't like to see. None of us should like to see that. What that tells us is that there's something we're not doing yet. If we're trying to deal with the opioid crisis and things are just getting worse and worse, well, obviously there's something we're not doing quite yet. Even the age-adjusted death rates from just prescription opioids have gone up quite a bit. So that sets the background, and I've got references here, and you'll all have access to these slides later on if you'd like them to look up those references. So let me just take a step back and let's talk about pain for a moment. What pain is, and this is a lecture, a didactic that I'll often give to residents here at Sarah Tucson. I'm going to present a similar presentation to psychiatric nurse practitioners in Tucson here this evening. I did it in London about 3 weeks ago. This is a good way to launch into it. So I'm going to present a case here of a teacher, school teacher with 3 young children, married, double income family, who presented to a pain clinic I was working in about 15 or so years ago with pain all over, and a lot of medical complaints, including fatigue, insomnia, nausea, that sort of thing, not responding to traditional medical treatment. Now, she led with pain. I'm hurting all over, so she had been kept in the medical system, neurologists, rheumatologists, pain clinics, primary care, and so on. When I saw her, these were the days of a lot of oxycodone. She was being prescribed a fair amount of oxycodone. And she had a family, her in-laws had addiction in the family history, and she was being questioned and pushed, you know, you're just a drug addict, you're drug seeking, and that's really not how she came across. But the point of saying that is, you know, this was really a miserable situation for her. She was using that medication exactly as prescribed when we checked up on her. Now, the diagnosis that she had been given was fibromyalgia, but she'd also been given and had taken away systemic lupus, multiple sclerosis, POTS, neuropathy, Lyme disease. She'd actually had tens of thousands of dollars of treatment for Lyme disease. That didn't help. It actually made her a little worse. And this was her pain diagram. So here's a lady 15 years ago doing very poorly, telling her, she and her husband present into the office, and she's telling me that you're our last hope, Dr. Davis, and here's my pain diagram. Notice that it says my legs hurt so bad it scares me in this slide. That just kind of file that away, that emotional content. Well, I asked, you know, what happened when this began? Were you sick? Were you in the hospital? Did you have the flu? Did you have a vaccination? I don't know. I was grasping at everything and nothing medically. And of course, when I was seeing this, I was thinking, maybe some trauma trigger had come up, and I couldn't pull anything out. And literally, as she and her husband were walking out of the room, her husband pulled her back in and said, could this, you've been asking me questions about trauma, could this have anything to do with it? This is the classic case. This woman had been in a hostage situation about a month before her pain began, 3 years before she saw me. And that was it. And that month lag is not a coincidence. It takes about that long for the epigenetic machinery to kind of change the nervous system. And she started having the pain all over, the insomnia, the fatigue, the brain fog, and so on. It also turns out that she had, when we got to know her better, we talked about development, and she had a high ACE score. She had quite a bit of developmental trauma. So she had been primed to have her nervous system triggered by this hostage event. Now, still, there's so many take homes from this. We don't have time to go in. One is patients aren't even aware. She wasn't even aware of the connection for many reasons. She had suppressed a lot of the memories, and she was really in kind of freeze mode, not really recalling what had happened to her. And it took her husband to kind of pull that in. But also, after treating her with, I think it was EMDR, yep, that's what the slide says, it was just EMDR. That was really about the only intervention. She went back to work and her pain was better. So another message here is that strictly monotherapy for trauma recovery was her pain cure. And if nothing else sticks from this, that I want that to stick, which is why I put it up front. She recovered and actually went back to work. 4 months after I first saw her, she came in and proudly told me that she disposed of all her oxycodone and gone through withdrawals. We didn't ask her to. We wanted to taper it slowly, but she had done that. So that also tells you that that medicine was not calling to her. With the trauma treated, we couldn't treat the pain without treating the trauma. Trauma treatment was the pain treatment. And then she was not dealing with the medications. She was able to be tapered off her benzodiazepines and so on. That's a really important thing to talk about. Now, I'm going to share with you some of the things as I go through this that I think you all know, but that's kind of how I've found over 20 years to talk about this with patients. This patient was at least 15 years ago. And the hard thing that's been hard for me is, how do I bring this up when patients aren't aware of what's going on without triggering them, without communicating that I think it's in their head and so on. It's really tricky. That's true of all psychophysical problems. So what I'll tell people is that trauma is an evolutionary biology predator proofing adaptation. We've evolved to respond to and to become wary of predators. That's what our fight, flight, freeze system is really about. So I'll give them this evolutionary biology definition of a long-lasting neuroplastic adaptation, not a disorder. It's an adaptation to threats, which the individual under threat couldn't master at the time that the threats occurred. So that's how I'll roll it out, not all at once like that. But that's what I'm going to be using as a definition for trauma. It's a change in the nervous system in response to threats that one couldn't master. It's an adaptation to keep us safe, predator proofing. Now, I'm going to give you a functional definition of pain as well. I'm going to tell you that for the purpose of this, let's define pain as anything that gets the pain circuits going in the brain. So here's two pain circuits in the brain. Blue is the somatosensory circuit. Red is we could call it the emotional pain pathway. Pain processing is more distributed than this, but we don't need to get into the weeds on that. There are really two ways we process it. Pain signals come up from our body, and we process them up here to tell us what part of the body. You just stepped on a tack with your big toe, left foot. This part is discriminating that for us and helping us stay safe. This part, the emotional pain pathway, uses the same real estate, the same brain real estate as the emotional pathway, the trauma response pathway, amygdala, basal ganglia, insula, anterior cingulate, and so on. That part, therefore, codes for the emotional content of pain, the miserableness of it, that sort of thing, and that relates to her diagram. So if this circuit is very active, people are going to be having a miserable time. If this circuit is the only one active, they're going to be responding without a lot of emotion to try to protect themselves. Two brain pain circuits explained there. And the point I'm making here is that we're going to call anything that turns these circuits on pain. So the question is, what can turn them on? Let's go through the four things quickly. So this is the meat of the sort of the biology of the presentation that I want to lay as a foundation. Whole nother discussion of, wow, how do you roll this out to patients and integrate it into a practice? So there are four ways that the pain circuits can be turned on. Let's talk about number one. We call this nociceptive pain. This fella's big toe's being heated up. It's sending a signal in his nervous system and letting him know to move his foot. This has been around for hundreds of years, this idea. And this is the more medical nursing school biology, same diagram. There are nerve endings, specialized nerve endings of specialized part of our nervous system dedicated to sensing pain that terminate the end here in the skin, in this example, that can sense things that can damage us. If those specialized nerve endings sense damage, they will send a signal up through the spinal cord to the brain, to the two pain centers. Now, what do these things sense? Well, anything that would hurt, too much pressure, too much heat, too much cold, and inflammation, which is actually a lowering in the pH, acidity in the tissue. So you've got specialized little nerve endings that sense pain throughout the body, especially in the skin and the mouth and so on, and on the bottoms of the feet and the hands to warn us what's going on. This is an important system, folks. If this doesn't work, we don't survive. And in fact, about 1 in 10 million, I believe, live births will have a defect in the nerves that are connecting these sensors to the brain so that they don't work. They can't feel pain. They can feel light touch, warm, cool. Those are different sensations, but they can't feel pain. And for up until recently, those children generally couldn't survive into the teenage years because they have too much damage, too many infections, things like that would overwhelm them. So we need this to survive. And the way in a diagram that this works is there's a pain stimulus, inflammation, heat, pressure, so on. It's processed through the nervous system. I'll just lump all that peripheral nerve, spinal cord, brainstem, the brain. It's processed through the nervous system. The pain circuits are turned on and out comes pain and disability. So here's the two pain circuits, the sensory processing one I showed you, the blue circle, and the red circle, the emotional processing. And out of this, we get the distress and unpleasantness. Out of this, we get the out, I'm just stubbing my toe. And in the end, we get pain, chronic pain, acute pain, disability, and so on. Now, what I've just showed you is called the nociceptive system because those little specialized nerve endings are called nociceptors. That's just a fancy way of saying in Greek, pain sensors. So nociceptors, we call it the nociceptive system. This is the acute pain system. We've all had pain from this. For sure. Sharp, dull, aching is how people will describe it. That's simple. And this is why many medical doctors will, if you go in and say, ouch, my knee is hurting, they'll sort of track back to the knee, the sensors in the knee, and try to figure out what went wrong, where there's too much inflammation or pressure or something going on. Now let's talk about number two. So there's four. Neuropathic pain from nerve injury. And this is a special case. When we injure nerves, our nervous system goes through a whole process to try to repair the nervous system. And that's where things can go wrong. And we can get neuropathic pain from nerve injury. So what's happening, I'm going to use this diagram, is this. There is not too much heat, cold, pressure, inflammation being processed in the nervous system. Instead, there's a physical injury to the nervous system that modifies itself, it rewires itself, the nervous system does, think spinal cord rewiring itself, think the brain too. The central nervous system rewires itself in response to the injury to try to repair. That can sometimes change the way we perceive sensations. So there's what we call altered nervous system processing of sensory stimuli. And what can happen when the central nervous system starts to get things wrong is even light touch can be perceived as being painful. Now, diabetics with diabetic neuropathy will say, when I'm walking on the carpet, it feels like hot rocks or sharp rocks. It isn't. The central nervous system is getting the signal wrong. It's taking a not painful signal and rewiring it, rerouting it into the pain pathway. That doesn't happen when we break a bone, thank goodness, or when we have a tooth pulled or a cut or something like that. It happens when there's injury to nerves. That stimulus, damage to nerves, triggers a whole different sort of a process that we're talking about now. We can call it central sensitization if we want to. The nervous system becomes sensitive and just lump it together as that. So that's neuropathic pain from nerve injury. And when this happens, the nervous system can even make up pain signals and send them to the brain that have nothing to do with reality. And the classic case would be phantom limb pain. So imagine somebody's lost a leg, yet they're perceiving that their foot's still there. That's phantom limb sensation. And they're perceiving that it's being crushed. That's phantom limb pain, if you've heard of that. There's no leg. Those are two lies. There's no, the nervous system is reporting to the brain there's a foot and it's hurting. So that is a spontaneous, made up phantom signal coming from within the nervous system. Exactly how that happens, we don't know for sure, but we know it's coming from within the central nervous system or being reported to the brain. And that we know, here's the thing, we know that the brain pain circuits that I showed you, both of them are red hot. They're spinning in the areas specifically that used to be reporting from that foot. That would be the same case in the diabetic. The diabetic's brain pain circuits are on when they're walking on the carpet and perceiving hot rocks. Normally, you or I, we'd walk on the carpet and the pain circuits would be quiet if we were to scan the brain with a functional MRI. So examples of this, I've given you a few: diabetic neuropathies. There's others, phantom limb pain and others. Phantom limb pain, if you've got a patient, switching gears for a moment, who is trying to understand pain from the nervous system, how the nervous system can just make stuff up and send it to the brain in response to nerve injury, phantom limb pain is a great way to explain it to them. Ask your patient, where do you think the pain is coming from when a soldier has lost a leg and the foot is painful? They've got phantom limb pain. It's not coming from the foot, and it's not just coming from the head. It's coming from in the nervous system. And that gives you a sort of a leg up, a foothold on how to talk about trauma and grief and pain, that sort of thing. That's where I'm going with it. People will often describe this second type of pain, neuropathic pain from nerve injury, as burning, shooting, electrical, that sort of thing. A little bit differently from aching, sharp, and dull. Okay, I want to go through number 3 and 4. And 3 is the big one that I was building up to. I've told you that the nervous system can make stuff up to report to the brain in response to physical nerve injury. It turns out that our nervous system, as it's rewiring in response to experiences, threatening experiences, can do the same thing as it does with phantom limb pain. It can start sending pain signals to the brain and turn the pain circuits on when there's nothing going on in the tissues. Think back to the case I presented you. There was nothing wrong with that woman's tissues. She had been biopsied and x-rayed and MRI'd and tested, and she didn't have inflammation in her joints or her skin or her muscles. The pain she had was coming from in the nervous system itself. Body, nervous system, mind, it was coming from within the nervous system to the mind. And this has been recognized 9 or 10 years ago. It was sort of recognized by the group that makes up creates the, it's kind of like the DSM-4 or DSM-5, the International Association for the Study of Pain, comes up with a DSM analog to painful diagnosis. And they said, okay, we know now that many people report pain in the absence of tissue damage or any pathophysiologic cause. It's no damage to nerves or any tissue. They said this happens for psychological reasons, and I don't like that. Saying psychological pain to a patient that it's tantamount to saying you're making it up. So I wouldn't recommend using that term, but here they are saying, there's this phenomenon where pain can come out of nowhere for psychological reasons. Well, what sort of things can lead to that? So let's talk about trauma. I'm going to talk about number 3, neuropathic pain from threatening experiences that reorganize the nervous system. Remember that injury to nerves, physical injury, like in an amputation or diabetes, can cause reorganization in the nervous system such that it gets sensations wrong or makes things up. Well, it turns out experiences can do that. You don't have to be injured. Threatening experiences, I will go out on a limb and say they can create a situation where the nervous system is sending pain signals to the brain when there's nothing going on, spontaneous pain signals, just like with nerve injury. So traumatic experience changes central sensory processing. That's same as nerve injury, except now traumatic experience, as we've defined it, leads to altered processing of sensory stimuli. It's the same diagram, except it's central sensitization from trauma. Actually, this is the trauma. The trauma is the reorganization of the nervous system, right? That's what trauma is. That's how we keep the score. Our nervous system keeps the score, so to speak, by reorganizing itself and holds on to it. So from decades ago, we've still got the score. We've still reorganized our nervous system so that it works a little bit differently to protect us. So we're seeing central sensitization from trauma here. So non-painful stimuli can be perceived as painful. I don't know if you're aware of this, but in fibromyalgia, some of the diagnostic criteria are pushing not very hard on different parts of the body and asking the patient if it's painful. The definition of fibromyalgia is that at least some number of pressure points will be really painful. When you're not putting a painful level of pressure on, that means there's altered sensory processing. Somewhere upstream in the spinal cord, in the nervous system, they're getting it wrong. Their nervous system is getting it wrong. And then turning on the brain pain circuits. That's what was happening in that patient I presented. She did have tender points, but just sitting still or waking up at night from a sound, she was experiencing pain from her whole body too. So she was having this happen too. She was having the nervous system report spontaneously that her body was hurting. It was all over. You saw the pain diagram. This is what I think was going on with that gal. This is what we believe is going on with fibromyalgia. And I'm going to take 5 minutes, maybe a little bit more, to go through some of the details in the literature that support this. I'm not just going to say this is the case without giving you some evidence. I'm trying to have some balance here, not drowning you in the evidence, but there'll be some. People often describe this type of pain from trauma, we'll call it, as cruel, punishing, fearful, and horrible. That emotional pain circuit predominates for whatever reason. It's really the primary pain circuit that's spinning. And they'll use these words. People in a post-op ward after a knee replacement and so on won't use these words to describe pain. These discriminate between people with pain from trauma and people with either nociceptive or neuropathic pain from nerve injury very, very well in research. And that's what I was explaining there. With this third type of pain from trauma, this circuit is more active. So before I go into some of the literature, here's another way of schematically. Obviously, I like diagrams, right? So here's a diagram. Trauma, toxic stress change our nervous system at its root. It rewires itself. That's actually a change in the way DNA is read and transcribed. And there's a lot of consequences. This is the trauma tree, and this is the fruit. Part of the fruit is chronic pain, but other things that you're aware of as well. So that's one way that you can kind of tie the sometimes depression, anxiety, fatigue, brain fog, chronic pain, that kind of thing. You can help tie them together as a change in the nervous system, and helps people really validate what's going on and help them. Sort of pushes back on this notion that they're the only one on the planet that's like this, which they will carry along. It's part of the shame and that sort of thing. There's something fundamentally wrong with me. No, it's just biology. It really helps with the just biology discussion. Okay, some evidence. Here we go. So 3 studies here. Again, these will be available to you with, they're all referenced, to show that if you take people with a history of trauma, especially developmental trauma, physical, sexual, neglect, that sort of thing, and you test their pain sensing nervous system, and this is 3 studies using 3 different ways, you will find that their nervous system in some ways is more sensitive to stimuli than controls who didn't have trauma. So that suggests, yeah, there's a change in the central processing that I told you about. What Dr. Davis said is true. These 3 studies, I picked 3 of many because they use different ways of producing experimental pain. Deep pain thresholds, just pushing on a joint. Hand immersion in cold water. Question is, how long can you stand that before it's too painful and you want to take your hand out? Well, the people with trauma could tolerate it less. Ischemic pain from blowing up a tourniquet on the arm. When do you want the tourniquet down? People with trauma history wanted that tourniquet down a little sooner. Particularly though, pressure pain. People turned out to be more sensitive to pressure pain. On the average, if you took 50 people with trauma, 50 without in their history, the people with trauma will have a lower pressure pain threshold. So that shows there's a change in central processing probably. And there's a really strong association throughout the medical literature, behavioral health and medical, between PTSD, trauma, usually PTSD is the diagnosis, and chronic pain. And I'll come back to that, but they tend to show up together. So that's association. Now, just being associated doesn't mean that trauma causes pain. That's not enough. But there's a lot of it. And this is an example. Chronic pain patients will have a prevalence of PTSD of about 42%, with a range of 4 to 95%, whereas the general population is around 7%, and even combat veterans are lower, almost a third or so as likely to have PTSD as people with chronic pain. So PTSD really pops up a lot in people with chronic pain, surprisingly so. And I'll talk more about that. Now, here's something a little tricky. If you just look at that bottom graph line, it's going up. What they're saying here is the dose of developmental trauma as measured by the number of ACEs. As that increases, the number of expected painful conditions in people will increase. In other words, a higher dose of exposure, a higher dose of developmental trauma, more likely to have chronic pain. That's called a dose response of the thing we're looking at, which is trauma. When you see a dose response, you start to think there might be causation. It's not just association anymore. Maybe developmental trauma and the degree of it is actually somehow causing pain. And I kind of did this backwards. I gave you sort of schematically how I think that works, similar to nerve injury. Finally, if trauma is causing pain, is causative, not just associated, but causative, you would think that treating trauma would relieve pain. And I gave you one case to show you that that's true. And I'll tell you there are now 6 randomized controlled studies of just EMDR as the sole treatment for chronic pain conditions, headache, back pain, fibromyalgia, abdominal pain, a variety of ones, as the sole treatment, just EMDR, just a trauma treatment, showing that it's really effective, not just statistically significant. I believe all the studies showed a really clinically significant improvement as well. So now we've got trauma associated with PTSD and trauma associated with chronic pain. There's a dose response, and treating trauma treats chronic pain. We got fairly solid evidence for that. Now, regarding depression and anxiety, let me just touch on this. Maybe what we're seeing is that depression and/or anxiety is causing chronic pain. The evidence isn't good to support that. The evidence is not there along the lines of I just showed you for trauma causing pain. If you do the same sort of analysis, anxiety and depression seem not to necessarily cause pain. As a matter of fact, a lot of folks with depression have higher pain thresholds. So this is just a slide saying, look, there's really no differences in pain tolerance if you look at all the studies taken together, looking at the relationship between depression and pain. I'm not saying depression and anxiety make everything worse in one way or another, but it doesn't seem to cause pain. And here's a study from the VA looking at anxiety, just to kind of parse this out. So if you have a patient saying, I think my anxiety causes pain, they're associated. As anxiety ramps up, pain will ramp up, but it's not causing it. There's something deeper. There's a change in the nervous system from the trauma, from the threat, that's really causing the anxiety and the pain, in my view. Let's look at this one real quick. The VA looked at pressure pain thresholds. So here's the pain threshold where this line becomes colored. As you increase pressure on an elbow, on a bony prominence, as you slowly increase the pressure, study subjects with anxiety and control had kind of a linear response. They said, yeah, that's more pressure. Right about here, this amount of pressure, on average, they said, no, that's painful, and about you keep increasing the pressure and stop. This is what the trauma, the PTSD group of veterans in this study with 3 arms, anxiety, control, and PTSD, showed. As soon as it became painful, they could not tolerate it. There's something different going on in their nervous system, only in the group with PTSD, not the group with anxiety. Anxiety tracked with control, PTSD did not. So that, I thought, was pretty interesting evidence that we're dealing with something unique, that trauma is kind of unique in what it does to the nervous system with regard to physical things like perceiving pain. So I have told you now that I believe that trauma causes pain through this mechanism, maybe somewhat similar to the mechanism we see with injury to nerves, like phantom limb pain. I'm going to give you a second way that I think trauma and pain, and trauma is causative, if you want to call it this. And that's really simply this. We all know that traumatized individuals have difficulty distinguishing current danger from triggered trauma memories of danger. So if I've got someone who's really triggered in the room with me, they're perceiving danger and they don't know if the threat is here in the room or if it's a triggered memory from the past. It's all the same. The physiology and the experience is the same. I'm going to tell you that I think it's pretty clear that sometimes triggered memories of danger include pain, often because what happened during childhood or whenever it happened was painful. So I'm going to tell you that traumatized individuals can have difficulty distinguishing current danger and pain from a triggered memory of pain and danger. So what am I saying here? I'm saying you can have triggered memories of pain. Yes, I think those people who have episodes of severe pain that seem to track right along with being triggered with a big increase in anxiety or panic attacks, and then they're fine in between, maybe going to the hospital. I've had patients who go to the hospital twice a week with these terrible pain episodes. They present with abdominal pain, back pain, pain all over, and the ER doesn't know what's going on and it just keeps happening. Well, those are triggered trauma events that include pain. That isn't really the same as a sensitized nervous system, is it? It's not constantly oversensitive. It's very sensitized to physical stimuli. It's just here and gone. It's more of a literally a cognitive psychology type of event of a triggered trauma and memory of pain. People can have both, but I've had patients that just had triggered pain episodes, and when their window of tolerance was increased, when they were less easily triggered, those went away or decreased. So I think there's two. I think you can have central sensitization, altered sensory processing that kind of sticks around, and triggered trauma memories of danger and pain. Now here's the key thing. If you're ever talking about something like this with a patient, both of those can be treated much easier than damage to the nervous system, say phantom limb pain from an amputation or diabetic neuropathy. All the evidence says that central sensitization from traumatic events, from threats, can be reversed. Like that patient I presented, one reason I presented her. And all the evidence tells us that's available tells us that these triggered trauma memories of danger and pain can be more or less eliminated so that people will be having a lot less pain. And that is a huge step for patients to hear that. If we get them to that point, it's treatable. I give a version of this to the residents here at Sierra Tucson frequently, and someone always stops me around this point and says, "But is it treatable?" Before I get to what I just said. This is common. I want to emphasize that this is a common thing. We see from the literature that the only thing that truly predicts who will develop chronic back pain are psychological factors. When you go back and look at these studies, they were before that ACE study was really out. The psychological factors they're talking about, we would probably all agree that they are trauma symptoms. Not only that, but people who, once they develop back pain, studies looking at what predicts who will respond to conservative treatment like exercise, chiropractic, physical therapy, and who will fail to respond. Same thing, trauma. So it seems like the psychological factors, if you want to call them that, and the one I'm really going to put my finger on is trauma and also grief when I come to it, that they're really the important thing determining who gets chronic pain, in this case chronic back pain, and who will respond to treatment. So that's the second study looking at who will fail to respond. Now, again, if you look at this, in PTSD, the prevalence of PTSD and chronic back pain up to 42% compared to the general population. You've seen this slide before, up to 42%, 20 to 42%, much more common to see evidence of psychological trauma in people with chronic back pain. This number 3 is really common, and we haven't been out there looking for it. as trained as an orthopedic surgeon and then in some rheumatology and neurology, I wasn't looking for this necessarily. I knew in the back of my mind it's important, but I wasn't looking for what really turns out to be maybe the main cause of chronic pain in our country. And there are clues to this. You know, you'll hear people say nothing works for my pain besides psychotropic type of medications. Keep in mind that opioids are pretty good psychotropics as far as good, meaning they relieve some depression and anxiety. Good as a good idea to prescribe them that way, not so much, of course. They'll have diffuse pain with no clinical cause evident. Think of that patient I presented, just like her. They'll have multiple somatic complaints. This is more of a psychophysical condition, so it's typically not just pain. The GI system doesn't work. They've got brain fog. They've got variable numbnesses moving around their body. Lots of things aren't working right because the trauma involves more than just the sensory part of the nervous system. Disabilities, bad, out of proportion, emotionally charged behaviors in the office, crying and so on is sort of a giveaway. And when patients say I cry in pain, we did a little quick study at the University of Arizona over a decade ago. 100% of them had, well, the average ACE score was 7 when they said they cry in pain, but all of them were diagnosable with PTSD in a small run of about 20 people we looked at when we stopped. It's like, okay, I cry in pain means that emotional pain circuit is really predominant. And that apparently only happens under conditions where there's been quite a bit of trauma. Most of these people didn't know about it, just like our patient. 5'2", if you go back, if you've seen it or you haven't seen it, and you look at Lady Gaga's 5'2", she describes the trauma pain connection really well. It's a neat thing to kind of connect people to, and I've had patients go and look at this and say, oh, that was really helpful. Kind of normalizes my experience. If she has it, well, I'm not so different. Number 4, social rejection, grief, and isolation. I'm lumping them all together as sort of close cousins. Grief is painful. We've got evidence for that. Social rejection is painful. I don't have time to go into the research behind that, but I think I have some slides in it. From COVID, we've really got this nailed down, but we knew before that isolation is painful, in that people become more sensitive to painful stimuli, et cetera, et cetera. Now, these things, social rejection, grief, isolation, they don't necessarily reorganize the nervous system. People seem to respond faster. So people who are coming out of an isolating environment so often to a residential therapy will say they feel so much better, less pain within a week or two. That's the resocialization effect that we're seeing. But this needs to be on there because many of our patients will need specific grief therapy. So here are the 4 things that can cause pain. Cause the pain circuits to turn on. That's more clear. Nociceptive pain, nociception. Neuropathic pain or central sensitization from physical nerve damage or disease of the nerves. Neuropathic pain from threat exposure, okay, from trauma, where actually the trauma is the change in the nervous system. And there's 2 types I talked to you about. This central sensitization, where you'll see pain all the time, and grief and triggered trauma memories, and then grief, rejection, and isolation. So this is kind of what I'm looking for. This is my differential diagnosis when I'm talking to someone with chronic pain. We're talking about chronic pain now. Which of these is active? And as you can see, I'm going to need help from my behavioral health colleagues when I'm working this up. Of course, anxiety and depression make everything worse, and culture, beliefs, values, assumptions, that changes how we interpret the pain. So the brain pain circuits may be on, but how we behave, how we interpret that, that's going to be a whole nother story. It depends on what's going on in the person's life and their culture, beliefs, and so on. And family and work. Oftentimes chronic pain comes about and people realize that, oh, I can kind of arrange my life, or it works to cope with, people nagging me, that sort of thing, or I can get out of school, that sort of thing. There becomes a whole nother layer that's active with the family dynamic in particular. So many of our chronic pain patients, we can't really get at it unless we have some family work that we're doing. Now, this is really important. This isn't a cause of pain, but I believe it's really important. I would really recommend, if there's one thing you dive into, it's this article by Richard Lane in Psychosomatic Medicine from 2018. He's a psychiatrist here at the University of Arizona. And the title says it all: biased competition favoring physical over emotional pain. A possible explanation for the link between early adversity and chronic pain. What he makes a very strong case for is that pain, focusing on pain, can become a primitive coping skill for not having to deal with, experience, think about, remember, feel painful emotions that relate often to trauma and that sort of thing. And those often are the people who are just kind of married to their physical thing. It's like, nope, treat my back pain. If you treat my back pain, I'll be better. Don't talk to me about my trauma. It's something in my back. It's my back pain. And despite overwhelming evidence that that's not the case, they kind of stick to that. This article explains that those patients, they're very tough. They're very tough because they can't let go of the pain, stop focusing on that, because then they're facing the emotions. They can't really do that until we have a better stress tolerance. We've helped them improve their stress tolerance and a variety of other things, maybe dealt with some of the grief. Then they can start to we see them let go of the pain. But how do you get them to agree to the working on the stress tolerance and the grief work and all that? That can be tricky. That's a whole nother talk. So the pain cake is this: nociception, neuropathic pain from tissue injury. Those are number 1 and number 2, number 3 and number 4, and then cognitions, emotions, relational modifiers. When you see someone who's saying, I have chronic pain, that's one of my main, if not my main problem, help me with this. The cake isn't cut open yet. You just see this big white blob. You don't know which of these layers are really important, how big they are. They're all equal here, but that's never the case. Now, I'm trained in these 2 on the bottom, the blue and the purple, but these all take you folks. So really the message here is we're not going to get very far treating chronic pain if we don't do it as a group. Now, we haven't been, and we haven't put resources to the 3rd and 4th type of pain, chronic pain thing that turned the pain circuits on. And I believe that explains a lot of what we've seen since 2010. I gave you that slide earlier. This is the graph version of it. This is the opioid crisis taking off. And it's predicted to continue taking off through 2025. I think, I'm going to put it out there, that one of the main reasons is that we're not really doing an adequate job of picking up on diagnosing trauma, grief, and so on, and treating it, particularly because many of these people are caught up in the medical system. That's starting to change slowly, but the resources are still difficult to come by. Just try to get, I know in my community, one of our community health clinics I know has a 1,000 or so patient waiting list to get into behavioral health who have been diagnosed with chronic illness that really relates to the trauma. That's not working for us. And those 1,000 people are still getting sicker and they're still at risk. I think that's really the foundation of it. I don't have time to go into a lot of these slides with you. Just that we know so many things now, having started to address the opioid crisis as if it was mostly, if not exclusively, an addiction, a use disorder problem, when many of those people did not have use disorder. They were people like that gal who didn't have a use disorder, but they were at high risk, and she could have died of an accidental overdose. If she was stressed out, she might have taken an extra Valium and even accidentally taken an extra one of her oxycodone if she forgot and not woken up. It could be that at least in the first 10 years, that was the majority of people. Not that I'm not negating the fact that there's been an increase in addiction, but I'm saying there's something else. Now, there's more evidence for this. We know that as we were enthusiastically tapering people off of opioids this last 10 years, that we created a whole other crisis of suicide and psychological decompensation. Here's a paper out of UC Davis that talks about that. Patients prescribed stable long-term high-dose opioid therapy, tapering events were associated with increased risk of mental health crisis. Why? Because their opioid was a psychotropic. Without knowing it, medical people, my colleagues, we got people started in this country on a lot of opioid, primarily functioning to kind of temporarily widen that window of tolerance or numb them out enough so that being out of that window of tolerance wasn't as uncomfortable. And that was the primary reason. So of course, taking the medicine away, if that's what it's primarily doing, leaves them in the lurch and they don't do well. And we're starting to see the effects of that. The FDA even said this. So here's my message in the last minute or two relating it to the opioid crisis. Opioids have powerful anxiolytic effects. Plenty of animal data and human data to that end. Often people with chronic pain were prescribed, and still are, combinations of opioids and benzodiazepines. Benzodiazepines because what we're really doing is treating psychological distress, not a acute pain issue like a broken bone or a burn. Chronic pain is different. They were often prescribed in large quantities to people with poor coping skills and poor impulse control. That's our population of people with complex developmental trauma. Often replacing even appropriate root cause behavioral health treatment. So over the last decade or so, the moral injury to me, once I started looking for this, is to see the thousands of people who really had no behavioral health treatment with severe developmental trauma, ACE scores of 10. And all we were doing was medicating with a combination of opioid and other psychotropic medications. So I'll just remind you, and I'll tell you, I'm going to add one more statistic. So I told you that PTSD is common in people with chronic back pain. I want to throw this one at you as we sort of start to transition into questions and so on. Chronic back pain patients prescribed opioid, if you look at them, up to 95% are diagnosable with PTSD. PTSD is going to be much more common in a group of Americans who have been treated for chronic back pain with opioids. That's another way of saying, kind of turning it around and saying, oh yeah, the opioid was for the PTSD, which is causing part of the reason they have chronic back pain. We've kind of organized it very differently. Yeah, so you can see that some of these people will develop an addiction disorder. Some of them might die of an accidental overdose without an addiction disorder. We really, really have missed the boat, I think, on this. And opioid crisis will get worse until we screen for trauma, have the resources to treat trauma available to adults. Of course, keep improving our addiction resources because that's an issue. Support integration of care between behavioral and medical. Research this and address the social and environmental factors in our kids and our schools and so on that are driving the trauma crisis. So I would like to take a break here because I've been talking nonstop for a while and see what we've got on the questions. And one more time. It opened to the list of attendees, 175 of you, which is very much appreciated. I'm seeing a list of you, but not the questions. Expand this list. You do there. I saw several good questions on there just for a moment. One more time. There you are all saying yes, you can hear. So let's start at the beginning. Quite a few questions. One thing I will commit to is getting back to you folks who have questions I didn't have time to get to. If you would like that, I don't know if we can reach you through email, but if that's possible, I would like to do that. Let's see. What does the role of adverse childhood experiences play and the absence of supportive factors in an adult who presented with maladaptive responses in adults? So the role of childhood experiences through the trauma, the change in the nervous system, you know, among other things. So I've added to the list of bad things that come from that. We can have chronic pain and other chronic conditions. I didn't even get into the autoimmune disorders and that sort of thing. You know, those people, I guess the question is leading to this, those people will get sicker on an individual basis, and things like the opioid crisis will get worse as long as we don't have supportive factors, the ability to support those folks. And what role can somatic work play as a part of an integrated approach in treating trauma? Well, that's it. I mean, it just so happens in Tucson, Somatic experiencing was available. In the last 20 years, we started referring a lot of our patients with chronic pain for that. We saw much better results than with any other type of approach. Sometimes we had to help with painful joints and things like that, physical conditions, but by and large, like that first patient I showed you, somatic experiencing, EMDR, and many of the other things, such as you're mentioning here, somatic workplay as an integrated approach to treating trauma and somatic emotional release, were all part of the treatment paradigm. We don't have an analysis that tells us EMDR, SE, somatic workplay, somatic emotional release that's looking at factor analysis. You'd need thousands of patients randomized to those different groups to really answer that question. I'm just going to say my experience, anecdotally, somatic workplay is important. And you're right on. And this one says, I have a client who suffers from anxiety due to past trauma of attachment issues and parental issues. Yeah, gets triggered at random and shows signs of headaches, feels nauseous, and that sort of thing. What is important to figure out? Is it changing the sensors or figuring out what triggers her and understanding where it comes from? The latter. What understanding, when people start to understand what being triggered is and what their triggers are, they start to get a handle. I've noticed this being a non-behavioral health person, watching my patients get better with all the work that you folks do. And I interview them, I'll ask them, well, do you know what a trigger is? No idea. What are you talking about? 3 months later, yeah. And these are the things that trigger me, and here's what it feels like. Oh, okay. And they're starting to get a handle on and feel some agency in controlling what's happening with them. It's not an out of control mystery. It's hugely important. I hope I'm answering that question, because you're right on. Let's see. Got time for a few more. Yeah. Let's see. Ben, do you see trauma from different sources actually causes persistent dysfunction at the receptor level of afferent pain nerve pathways from Dr. Brown? I do. There's a lot of feedback to modifying the sensors. Remember the little nerve endings in the skin I showed you, the nociceptors? Well, those are modified as part of the overall reorganization of the nervous system, most likely. We don't have a lot of specifics on that very clearly, that how exposure to threat and trauma might remodel them. Changes in the stress response with increasing cortisol and so on definitely affects, through a variety of mechanisms, how our nociceptors, those pain sensors, work. So the answer to your question, short answer, yes. I think the changes in those changes are all, as far as we can tell, reversible through trauma recovery. How would you recommend talking to a close family member who you believe has physical complaints, pain, etc., that's likely attributed to the developmental trauma, but they're convinced it's about the medical issue? That's the part 2 of this. That is really tricky. The best way I can say is invite them in and say, I know some things that might be really relevant to what's going on. If you want to hear them, I'll tell you. Until they invite you, it's not really going to land well. Until they invite you in to talk to it. It's going to be particularly difficult if it's a family member. So the first step is wait for them to open the door and invite you in and ask. I really got some stuff I could share. Or why don't you, there's a webinar version of this available on the Sierra Tucson website, on my LinkedIn site, which is just this talk from a teaching seminar. Nothing oriented towards products or selling anything. It's just this talk, and that can be helpful for people as well to get them thinking about it. One more question, then I want to get to the 2 resources at the end. Let's see. Dr. Porges' work on the polyvagal nervous system and its role it plays with trauma and treatment is very hopeful. And there's someone's taking the docs and pharmaceutical companies to task. Yep, we all deserve it. Is there any push to insist that behavioral health treatment must occur when an opioid is prescribed? Yes, actually. That's very slowly changing, although there aren't enough of you. Our workforce is upside down. When I did my fellowship in England, it was 2 to 1 behavioral health to a medical person treating chronic neurological, rheumatological, painful conditions. 2 to 1 behavioral health to medical. And and they were busy. People who respond to trauma with a dissociative response, are they likely to have a reduced experience of pain? During a full dissociative response, yes, that's part of what it's all about. Before and after, no. That's for sure. So let me jump back out of this and just give you, I'm sorry I did not have enough time to get to all your good questions. I wish we had, and this would be a great roundtable discussion, really. But I wanted to give you these two books. The Way Out by Gordon from UCLA talks about pain in the nervous system. I agree with a lot of it. Don't like the way they present some of it, but it is a pain paradigm, kind of a branded one, but nonetheless, that talks about what I'm talking about if you're interested in going into more detail. And this book, Psychophysiological Disorders, Trauma-Informed Interprofessional Diagnosis and Treatment, Clark et al., that's pretty good. Again, I would modify some things, and I hate the word disorder. It's just an adaptation, a normal survival adaptation based on our predator avoidance system. But anyway, psychophysiological disorders, I would have said distress or whatever, trauma-informed interprofessional treatment and diagnosis. There's some good things in there if you want to take this a little further on looking, if you want to call it the mind-body connection, but it's really what happens in the nervous system, how that's malleable and plastic in response to our environment, and how that affects our physical health. These two go into it in good detail. So I'm going to stop. Thank you so much, all of you, for taking an hour to spend with me on this, and I'll turn it over to you, Lila, if you're still available.